We have a great program for you tonight. Thank you for joining us. We're going to be talking about Navident 3.0, full mouth rehabilitation, the new functional abutment selection and bone screw trace registration. We have a very talented panel here with a prosthodontist and a periodontist that work very closely together on some really exciting cases that they'll be excited to share with you. We have our first speaker is Dr. Selene Kuo, and she received her Doctor of Dental Surgery degree from Kaohsiung Medical University College of Dental Medicine in Taiwan, where she completed her education as a prosthodontist with the degree of Master of Dental Science. She continued 1 year of training in advanced education of prosthodontics at NYU, followed by an additional year of clinical fellowship also at NYU. She obtained the master's degree of dental science from Columbia University School of Dental Medicine in the prosthodontic division. She is the former clinical assistant professor in both NYU College of Dental Prosthodontics and Columbia University College of Dental Medicine, the prosthodontic division. Dr. Kuo lectures nationally and internationally, focused on digital implant dentistry. She currently serves as clinical assistant professor at Taipei Medical University School of Prosthodontics. Our second speaker is Dr. Tzu-Shan Chiu, and she received her Doctor of Dental Surgery degree from National Taiwan University in Taipei, and her Master of Science in Periodontics from Columbia University in New York. She's a diplomat of the American Board of Periodontology and a diplomat of American Academy of Dental Implantology in Taiwan. She has published several peer review and original articles in various dental journals. Dr. Chiu is a clinical assistant professor in Taipei Medical University, and currently she serves as a postdoctoral periodontal clinical instructor at the National Taiwan University, and she practices in multiple clinics in Taipei. She lectures both nationally and internationally on periodontics and implant dentistry. Doctors, the screen is all yours. Thank you.
Thank you for your introduction.
Thank you, Beth.
You're welcome.
Okay. Okay. Good evening, everyone. So it is actually our morning. There's 12 hours difference if it's for Eastern time, but good evening, guys. Today, we're happy here to share with you guys our full digital workflow featuring utilizing navigated machine for treating complicated cases like X full mouth rehab patients. So we're gonna quickly dive in. For your easier to understand, because we checked upon the list and we realized that there are some participants that are not so familiar with the digital workflow, even how to utilize the digital equipment like scanners or navigation machine. So the outline that I designed for you guys for in our lecture today is we're gonna start with the basic foundation and we are gonna gradually move to our feature, which is the latest version 3.0 of navigation machine, Navident. So the basic, it always start with the question, like core question, why should I go digital? Why can't I just practice as what we have been doing for the past 50 years? And how this navigation machine works, is it precise? How am I going to utilize it? Is it benefit for my practice? And the third question is, once I decide, once I want to get started to utilize this type of machine, how am I going to apply this type of workflow to such complicated cases that basically there's nothing is going right, everything's going so wrong, we don't have proper landmarks to start with. I'm going to walk you through our workflow, and there is an algorithm that we created. And the last part will be the features. So starting from why go digital? And this is actually, as I said, that's the core question that I got frequently asked from the podium. Because the doctor always, feel that there's not such a need to utilize digital since we've been practiced, as I mentioned, the conventional for the past like 100 years, and we seems to get pretty good result. So is that just the, like a lot of them, they will ask me, say, is that just like they buy you to say that? Is that the conspiracy from the company? Or is it truly it's going to be truly beneficial for your practice? So answering that question, I always like to talk about science, and logics. So let's start with what the actual problem, what the actual sore spot of the conventional dentistry that we encounter daily basis, and doesn't seem like a better your scientific or logic standard way to solve it. Just like Steve Jobs says, I love this, this idea. Any type of the technology, any type of the digital technology that is invented to fulfill the unfulfilled need, right? So basically it's like fulfilling whatever that we can never overcome, or what we always encounter the problem with. It's been designed. So starting with the conventional problem, this is my patient always walk in, and for the cases that's evolving more than only one tooth, it's like basically both arch full mouth rehab. You will take some record, and that's how you start with your case, because you basically want to predict how are you going to restore the teeth in the future, and maybe give shuffling a couple implants or give them denture, anything like that. You have to collect the data. So the conventional data that we get the best is by professional camera. We all get training throughout the years that we take precise camera to capture the detail for us to analyze the case properly. And we will take a couple x-rays, either 2-dimensional or the 3-dimensional x-ray, to being able to really start analyze how we're going to move forward, what's the treatment option we're going to provide the patient. However, there's always this major problem that I don't know about you, but I encounter in daily basis. That is, frequently, let's say we take a model, we take photos, and we are going to do a diagnostic wax up. We are working heavily, intensively transferring the new correct parameters to establishing the proper right teeth on the cast. However, we're analyzing everything through our eyes. And we need to use 10 tons of imagination in our brain to quickly analyze how we are going to transfer the information on our physical cast that we are holding on. So basically, we are utilizing a lot of vision, we're using a lot of imagination, and not to talk about when it comes to the communication with your partners or with the patients. Frequently, the first, for the right top, you will see frequently the diagnostic wax up, which is going to dictate your future teeth position, that are very off from the very end that you're going to place your teeth over, right? Because we are talking to our technician, not using a very scientific evidence, like they're more precise 3-dimensional photo or a more predictable vision for them to really understand what they're working on. And for the second one is also we're using our brain to synchronize the future teeth position along with the bone in our brain to place the implant as a second one, which is the freehand implant placement. Highly chances is like more than 90% of the chances you're not going to place implant predictably. So as I often joke around in university, we've been through both me and Dr. Chiu, we've been through this intensive specialist training in US. And the famous joke is, you always want to, when you first get the cases, you get exciting because you want to do a lot of implants or do, a lot of different prosthodontic design. You want to practice. And you thought that you're gonna get like a perfect smile, just as what you saw at the screen on the left. It's like perfect white teeth, patient's gonna smile to you every day, everything's gonna be great, like a dream. However, along the way, throughout the time, you found that the treatment is sort of being composed like piece by piece and nothing's going right? You're like, exhausting and running around fixing things here and there, and ended up, the famous joke is, you want to fix the teeth in a day, but you ended up have the teeth in a decade that you will never be able to finish. And that is just the perfect example of losing the control of cases, and that frequently the problem has been generated because of the problem that I just addressed from the conventional problem. So in order to solve the problem of the doctors as well as the patients, we don't want to waste the patient's time and patient feel very uncomfortable with you, especially during the treatment. The technology has been developed. It was actually once being utilized and broadly actually being utilized in industry, that nowadays we could be able to utilize it, apply that in our medical practice, hoping to improve the quality of the treatment. And what actually defines the quality of treatment is supposed to compose with a couple pieces that actually brings up the quality and brings down and reduce down the problem, the headaches, as I said. So the quality, it's a very number specific term. So if we look further into that, it's basically we want to improve the dental work in terms of its biology. It has to be biological friendly. You need to be able to clean around the teeth that you design, right? Otherwise it wouldn't last so long. And the second piece is you actually need to improve the function, the mastication of the patient, because the major concern and the major need from the patient is they need to be able to chew. And the third part is nowadays, especially the social media has been really, take the place everywhere. You need to not only give the patient back their ability of chewing, but as well as they need to look pretty, right? Otherwise they couldn't take photos on their Instagram or TikTok. So basically the biology, the function, the aesthetics that plays the major role in the future predictable teeth that you're supposed to serve, you're supposed to apply to your patient. And the last puzzle will be you want the teeth to last for more than a year. It's not just the teeth that you treat, you provide temporarily. You want this to be able to serve the patient for a longer period of time, just like anything you purchase. So durability is also the fourth part that I consider, it's genuinely very important. Things that you want to reduce is improving the quality. In terms of improving quality, is that you don't want to waste your time, as well as the patient's time. If they came for like 20,000 times, they lose confidence in you. And you want to potentially reduce the cost of your, reduce your cost of what you spend. If there could be a more control way instead of being back and forth, improving your efficiency in terms of treatment, as well as the most important part from a perspective. I don't want headaches throughout the treatment, because sometimes it could bite you hard. Like when there are times that when you're on your bed, you're keeping thinking about complicated or failing cases that you don't know how to solve it properly. We want to avoid that. So these are all what the technology in medicine, in dentistry, that's supposed to assist you. So let's take a look at the digital dentistry. So substituting what the two-dimensional image, we actually got this three-dimensional, intraoral scan. That's what we said, that you can flip it around and you can actually see further in your both hard and soft tissue. And then you have the three-dimensional of the cone beam scan. What's substituting your eyes is actually the intraoral scanner. You're not being biased. You're just capturing the data. And then you're being able to have the ability to design, to actually draw the design of future teeth on the very standard software. So everybody can see it, including your partners as well as patients. And then being executed through the machine that's being very controlled to tell you where to go. So you can design it and then you can place it properly and then manufacturing out according to your original plan. And that being said, is having control of your cases, and that's the value of digital dentistry. So moving on to how the navigation works, which is our main topic today. I always love to introduce it as a Google map. Navigation machine, just like any type of navigator, it basically gives you two abilities. One is to direct you to your destination, right? You want to go somewhere else, you use your Google map and it leads you to the way. And the second part, which is amazing, is it's not only giving you the destination, but also along the way that you're approaching to your destination, you get this instant and dynamic feedback, what's going on around you. So basically, if you encounter, a reconstruction area, you need to go detour, or you get traffic, you need to reroute it. This constant feedback actually instruct you, actually gives you information to avoid problem. And that is exactly what Navident navigation machine, its function. So in this slide, you can, in this movie, you can actually see there's a target there, but target is just secondary. If you look at in the middle of the screen, this cross-section view, you will see a plant yellowish implant position, and your green bar is where your future, you're actually performing on, the implant is inserting in. So it gives you, as what I said, the ability to follow your plan. It gives you the destination that telling you where to go properly, avoiding the surrounding anatomic landmarks that you don't want to touch upon. You don't want to hit it. You don't want to hit the nerve. You don't want to hit the vessels. And the second most important, the most important thing, but the second, features that I want to share with you guys is you have to actually not only being navigated properly, but you actually need to enter then your destination precisely as well. And that being said is where you see in the middle screen, there is a red outline of the teeth. You got to have the teeth superimposed with your bone, so you're following the teeth, inserting into the surrounding bone, that your implant's gonna be fine and it's gonna be restored properly in the future. And that being said, is purely just prosthetic driven implant dentistry. We want it to not only being osseointegrated in the bone, but we also want it to being able to function, and it has to be look good. So planning the teeth is crucial, and that is what actually the core structure of what we're getting started. We want to plan the teeth properly along with the bone, and we plan it properly where the implant future is going to be. And then we synchronize the patient's position along with this plan, so then you can execute it properly along what we're planning on. So, as what we talked about, planning teeth, that's the most crucial puzzle along with this whole idea of navigation, because it will navigate you properly. As I said, the machine is mostly correct, as long as you're feeding it proper data. The machine pretty much is 99% correct, guiding you to your destination, but you will never want to enter in the wrong destination. Otherwise the machine, otherwise the machine can only tell you this much. That being said, is you don't want to enter in your Google map your wrong destination and the machine correctly guides you to the wrong point. So just like this slides that I'm showing to you guys, if you plan your implant just along where the existing teeth are, instead of considering the future prosthetic plan that you're gonna change, because most of the full mouth rehab patient, the teeth are most likely it's gonna be gone. It's not gonna be at the right place. Otherwise, why are we extracting it, right? So you have to define where we are gonna put the teeth back and then work backwards, and then you can finally start to plan your implant position. So this is exactly where we want to get started. You want to have this 3-dimensional teeth that virtually being designed, and then you could be able to find the proper location where you want to place the implant. Meanwhile, examining through the bone that whether it's enough or not. So this is the plan part. As we talked about the plan part for the navigation to start with, especially for full mouth rehab, it's either failing dentition or fully edentulism. Not enough landmarks that is frequently encountered, Minimal landmarks, that's a problem we frequently encounter. And that is the reason why we want to, share with you guys, there are important information and data, as I mentioned, you have to feed the machine so that can guide you precisely to the precise plan that you want to have the implant in the future. So you can see the teeth, you're not going to follow the wrong teeth or failing dentition at this point. You will have this new set of the teeth in the future that you want to apply, just like your conventional diagnostic wax up, and you superimpose with the bone. Then you plan your implant according to your bone and your teeth, and according to, of course, your prosthetic design in the future. And with that, that brings up to our algorithm that we want to share with you guys. Starting from the left side, you will see acquiring the data as well as the virtual wax up. Then you will utilize this wax up, this future teeth plan to first on top of, for the first top aisle, you will utilize this data to superimpose with your bone. Then you will see all this yellow planning and then executed it along with your plan, utilizing navigation machine. And for the bottom aisle is for the same set of the design of the teeth, you're going to utilize it for your provisional or your future definitive teeth, right? Because the plan, it has to go along with what you're doing, what you're applying to your patient in terms of teeth. So the same set of design is what you're going to utilize to prefabricate this provisional shell for you to utilize it on the day for your surgery picking up, to provide the patient an immediate functional full arch provisional restoration. So let me quickly walk you through what our sequence is for full mouth rehab, as what I said, in terms of that algorithm we created. I'm gonna break it down more in detail so you can get a better understanding. First, we acquire, as I said, the intraoral condition. And the intraoral condition is mostly wrong. It's either failing dentition, just like the left side patient probably have a denture or just teeth moving here and there, or either it's just at the right side, the fully edentulism. You only have an edentulous ridge. Then you will have to utilize your fundamental knowledge as a doctor to redesign your teeth are going to be restored properly. So basically, that's the fundamental knowledge from your complete denture textbook, right? You have to put back the teeth first. So that brings to the next step is the CAD, the digital design of the teeth. You have to, we used to do it conventionally. We used to hold on the cast and do the wax up, use the wax drip by drip to redesign, recreate a future nice teeth. But now we're utilizing the software to redesign it. It's either, over the teeth or a denture look thing. So then to carrying on the next step, we have this nice teeth right now, and we have patient's bone information right now. How are we going to apply this new design of the teeth on top of the bone so we know where to drill our teeth along with the tooth and figuring out whether we have bone or not? So basically, we need to apply the teeth design and synchronize it with the current bone so we can start our planning of the implant position. And that is actually what I kept on saying. We need to feed adequate data to the machine so that it can afterwards navigate as well. And that is the puzzle that is the puzzle and the most crucial part for this algorithm. It's fiducials. So basically, the fiducials is the transferring marks that you're going to utilize to provide the patient this design, which you just don't have much, right? You don't have much to begin with, and overlapping on your bone. So basically, you will see the teeth in the model or in the scan, and you will also see this teeth under your cone beam CT. And that being said, is you use this fiducials to overlapping these two important information, both digital scan as well as the bone scan. And there are two different types of the fiducials. One is we basically applied it on top of the teeth, and the other one is we will have something fixated into the bone, and that serves different purpose. So the type 1 fiducial is we will have our digital wax up, and the digital wax up, we will either print it out or mail it out into a prototype that we tried it in the patient's mouth. So basically now we're delivering this digital prototype in the patient's mouth, but meanwhile carrying this fiducials, these transferring marks. So that allows me to have this information the prototype putting back to the patient's mouth with the fiducials. So you will see the denture with the fiducials that we marked on, and the patient will wear this fiducials, this prototype, to take a coping scan. So that's where the yellow star is. You will see it over the denture as well as the CT image. And that's how you superimposing the image together. And that gives you ability to know where the teeth positions are, and then you can insert and you can virtually plan your implant, the yellow implant position, along with the teeth, along with the surrounding bone. The second part is you want to utilize something fixed in your mouth. It's not only giving you the ability to overlapping the intraoral condition to your CT, as well as you will need to, as I said, you will need to transferring the information, telling the machine where you are. So this is the part that we need to synchronize patient's arch with the competency, with the plan. And that is what we call the bone pin. And Dr. Chiu is going to talk about this a little bit more. But basically, this gives you the ability to not only overlapping planning your case, but the most important part is you utilize this to verify, to register your patient's position along with your plan throughout the surgery. And that is the fiducial markers. So basically, if you're familiar with the navigation machine, these bone screws, it's not only giving us the ability to be able to synchronize the plan with your bone, but the most important part is we actually use it to trace. We actually use it to register our edentulism part with our edentulism arch of patient with our plan. Then we can following carrying out our surgery. So this is how the presentation that we actually did intraorally. So we will print out a prototype. The prototype carries a couple of fiducial markers, and then we will probably redesign it slightly, just move the teeth here and there, give it a final touch. And that is, so the second part of the design is we want to improve the position of the teeth for the preparation for provisional, for us to being able to perform the full arch immediate low. But the same set of the design, as you can see, we synchronize it with the bone, then we can be able to have the implant plan everywhere, along with the arch, along with what we're going to do in the future with our definitive prosthesis. And the last is you will export an STL carrying on the implant information along with your teeth position. Then you will have this information synchronized back to your original plan. So you fabricate out a full arch shell. That's what we call the full arch provisional, but having this pre-drill corresponding holes along with your planned implant. And the material selection, basically you can have it heat process milled or you have it printed out. But latest current science is if you want to have more strength, maximum strength and durability, milled full arch provisional is highly recommended and the most recommended for now. So you will see it's been milled out. So prior to your implant surgery, these are all prepared. And on the day of the surgery, we have the navigated machine, we have Navident to guide us to place implant properly, precisely along with what we have planned. And then we can just utilize this shell. You can see at the bottom, just insert in smooth, just, I wouldn't say just, easy as piece of cake, but still it gets you the ability to being very close to where your protocol is going to be in the future. You just need to somewhat adjust the hole accordingly, slightly, that you can be able to perform your full arch provisional immediate pickup. And this is after the pickup, you have to make sure everywhere is smooth and round and patient just good to go. So I'm gonna hand the rest of the 30 minutes to Dr. Chiu to talk about our feature for today, which is the latest version of the features that the Navident is gonna provide us. She will talk about the jaw trackers as well as how the latest version of the technology we can actually trace over the surface in order to achieve the synchronized steps as what I just described. So let's welcome Dr. Chiu.
Thank you, Dr. Kuo, for your wonderful presentation. And good evening, folks. I will continue from what Dr. Kuo have said and start to introducing all the new features that Navident come up with, and also how to be creative while you're using all these materials and try to make it work even better in your clinical work. Starting from the rationale of how Navident actually works, the machine, they're equipped with two detectors, which can detect one jaw tracker, and also the other one, it's the tracker mount on your handpiece or the instrument they are using. So they are recognizing the tracker that's in your mouth, which is recognized as the non-movable one, and to detect the one that's moving. So this is the basic rationale behind how Navident works on guiding your surgical procedures. So what's the new features that can actually help us out while you're working on your case? The new jaw trackers, there are 3 different kinds of trackers. The first one is on your left-hand side, which we call it jaw tracker C. That's the one you use composite to attach on your teeth or anything that's non-movable in your mouth. The second one, we call it jaw tracker B, which is secured by the bone screw directly. You screw it into your bone. So that's the one that's not movable in your mouth as well. The third one, we call it jaw tracker U. The jaw tracker U is the one you have a U-shaped type of clip attachment, and you use the by registration material, which you have to pick up the certain kind of by registration material to make it stronger and non-movable. So this one is more like a snap-on type of attachment. These are the 3 new type of jaw trackers that you can use while you're doing your surgery. And today we're talking about like the all kinds of full mouth reconstruction cases. So when you're working on this type of cases, jaw tracker U doesn't really work, because for the patient who has very minimum teeth or they have very mobile teeth, that's the indication of having full mouth reconstruction. So that's the reason why jaw tracker U doesn't really work in this kind of patients. So we will focus on jaw tracker C and jaw tracker B today. And in the very beginning, I say you have to be creative, because when we're using Navident, we start using Navident in about like 2 years ago, and back at the time there are not like you don't have so many choices for you to secure your tracker on the teeth. So we have to be kind of creative while working on the teeth. The picture on your top left, that's the one like the very regular type of use. You secure your jaw tracker C with composite on your teeth. Don't forget to put on some bondings before you secure the jaw tracker C. Otherwise, it could come off during your surgical procedure. So that's the first one, the very regular type of one. I usually like to secure my jaw tracker C using the undercut between interdental area. So that's the easy one. And then the one on the top right, there are 2 pictures. So for these 2 pictures, it's actually the one we did in about 2 years ago, or at least like a year or so. the patient has a few, like very few teeth remaining in the mouth, and some of the teeth are mobile, or it's very hard to secure the jaw tracker seat on only one tooth because it could rotate. And the patient happened to have a implant on his bottom jaw, and the implant is still stable. So we took off the crown on top of that implant, change it into a temporary abutment, and then we used the acrylic resin to secure our jaw tracker seat with the temporary abutment and make it work. And the bottom left one, that's the one you embedded your jaw tracker seat into acrylic resin. And so it's like a snap-on one. And because it fit into the patient's mouth because it's a customized one. So this one, you can take it on and off during the surgical procedure. And then the bottom right one, this is I'll call it a prototype of jaw tracker B, because for the fully edentulous patient, back at the time, we have no idea about how to secure our trackers on the patient's jaw. So this is how we like so-called being creative, and we put on acrylic resin onto the jaw tracker C, make it into like a jaw tracker B, and then secure the tracker into patient's mouth with bone screw. And then the bottom right one, that's the real bone tracker, the real jaw tracker B, which comes out later on, and with 3 screw holes, so it makes it even more stable, and also the material wise, it's more durable. So these are all the like all kinds of method to secure your jaw tracker onto your patient. And I'm pretty sure all the dentists are very good in securing things on your teeth. So everybody can have their own way in securing the jaw tracker, as long as it's stable, it's not moving, and can be reproducible. So the picture that I'm showing right now, that's my favorite way to do the surgery nowadays for the edentulous patient, for like fully edentulous patient or patient with very, very few teeth. So you can appreciate it from the picture that the patient has a obtrugate, which we use it as a mouth opener, and also it has the retraction type of function. And then once you put on the obtrugate, you can secure your jaw tracker B onto your jawbone, and then you're good to go. So this is for myself, this is the easiest way to do the like the best control of the surgery before we start doing the drilling part, like all the rest of the procedure. And then once you have your jaw tracker secure in patient's mouth, then the following step will be the registration method. The registration is the one you have to let your Navident to synchronize the intraoral condition to your cone beam CT. So it's more like when you're using your Google map, they have to know where you are before they can start to guide you. So this is the part that we have to let the machine know where you are intraorally. There are 4 different ways to do the registration. The first one is tracing. The trace, it's the one you use the tracker sliding on your teeth, and then so the machine can capture all the motions and synchronize your intraoral condition to your cone beam CT. And then the other 3, from Navibite bone screws to Navistent, these are different from trace, because the trace one, you don't have to put on any kind of device into patient's mouth before they take the cone beam CT, since it's capturing the tooth surface by the moving motions. Once you're tracker stay close enough on the tooth surface, that's how they recognize it. And then for the rest of the 3, you have to put on these devices in patient's mouth before they take a cone beam CT, so that the fiducials that Dr. Kuo just talked about will be recognizable on the cone beam CT. And when you're doing the registration, the Navident can easily recognize all these fiducials and superimpose the intraoral condition to the cone beam CT. For the fully edentulous patient or for the patient with failing dentition, they don't have enough teeth to put on the Navibite or the Navistent. So we will be focusing on the trace and the bone screw, this 2 type of registration method later on. Starting from the bone screw. The bone screw, you have to place them before you start to, before you take the cone beam CT. And the bone screw insertion, there are 2 different ways to do it. The first one is you just do it through the gingiva and with the screw head left exposed, just like the one you see on the picture on our right-hand side. The second one is you can do a small incision and then embedded your screw head underneath the gum tissue. That's the second way to do it. And for myself, I prefer to do it through gingiva because it's easier to recognize where your bone screws are. And also when you're doing the flap procedure during the surgery, it's easier to recognize where your bone screws are and try to avoid that, because this type of bone screw, it doesn't really integrate with your bone. It's just a pure mechanical thing. You screw it in, and then while you're doing the flap, because when you flap, you have to use some, like you push your flap around, and if it's embedded, sometimes you could accidentally remove your bone screw. If your bone screw it's removed, then there's no way you can replace it back at the exactly same spot. So it means you will not be able to use the screw when you're doing the tracing procedure, the registration procedure. And these bone screws, they have to stay in the mouth from the day you take cone beam CT until the day you do the surgery. If like you're doing some simple cases, you can even take a cone beam CT, import it into Navident, and do the surgery on the same day. But we're talking about right now is the full mouth. It's the full mouth reconstruction cases. For this type of cases, we have to take cone beam CT. We have to do diagnostic wax up virtually, and then we have to superimpose the image. Also, later on, we have to fabricate the temporaries. So it's gonna take about like a week to finish all this procedure. It's very hard to finish all these steps within just a few days. So always keep that in mind. You have to make sure your bone screw will be able to stay in the patient's mouth for at least a week or so, or sometimes even longer. So to secure this type of bone screws, it's actually it's a very difficult case because in some patients, they have to wear dentures, and it could also or when they're eating, this could always be like in the way. So some patient, they came on the surgical day, and you will be very surprised and also very shocked to see several of the screws they came loose. So it's always better to place a few more than what you plan to place. This is the case from the very beginning. So back in the day, we've always placed 4 mini implants, but for the patients who might lose their bone screw easier because of their bone quality, in that type of case, I will choose to place several more bone screws or switch to another kind of bone screw that can stay a little bit longer. And for how many bone screws that you have to place, according to the study, at least you have to place 3. excuse me, for the 3 bone screws, it's the minimum number you have to do while you're doing the registration. It's just always the concept you have to get 3 points to connect it. If you have only 2, then you will not be able to register your intraoral condition to your cone beam CT. So minimum number of bone screw, that's 3. Preferably place 4 or 5 or even more, because you might lose several of them during the waiting period from the time you take cone beam CT to the time you do the surgery. And the more, it's not saying like you have to place 10, like 4 or 5 or 6, that's actually enough. For the number of teeth or the bone screw that you trace, you have to get at least 3 to 4 to get the secure result. And the more you get, it's a little more accurate than if you only do it on 3 or 4. And distribution wise, your bone screw have to be widely distributed from the distal to the mesial to the surgical site. If not possible, it has to stay close enough to the surgical site. And also, if clinically possible, they should be spread along the arch, meaning you don't place your bone screw cluster on one side. It has to be like everywhere in the jaw that you're going to do the surgery. All right, so this is how it looks on the cone beam CT after you place the bone screw. And also there are fiducials on the temporary teeth that we use for the pre-surgical workup. And once you have all these bone screws, you can appreciate it from the screen. You can, this is the procedure before we do the tracing. You put on the landmarks on the bone screws for the site that you are going to trace. So this is how it works. And you can appreciate there's a number on the planned implants. So you can see some like 1 or 2. What does this mean? When you have enough bone screws or enough landmarks and stay close enough to the teeth and widely distributed, just like these bone screws, some in the front, some in the back, including like mesially, distally to all the surgical site and spread along the ridge. And once the number shows, let's see what does the number stand for. When you see 1 or 2 show on the screen, the circle is green. It indicates that you have a excellent registration accuracy. And when you have 3 or 4, it goes to the yellow light, which means you're okay, but you're not like as accurate for the registration part as the green light shows. And when you have 5 or higher, that means you have to add some more bone screws so that you can have a better registration accuracy. For this zygomatic implant, you can appreciate that if you only have your bone screws in the front, they stay quite far away from your future implant site. So you will see some like 5 or 6 on the implant, which means your registration is not accurate. So it's better to add some more bone screws on the palate. When it stays closer to the implant, you can appreciate that the numbers start to change. As the more you have and the closer to the future implant site, the number will goes down. So when you have it in the front and in the back, have all these implants incorporate in the field of your bone screws, you can see the number reduced. And as long as you have more than 4, if you have like 5 or 6, the number doesn't really goes down more. So that's why we say you need to have at least 3, 4 or 5 preferably, but you don't need to go like crazy, like 6 or 8 or 10. It doesn't really help a lot. And for the bone screws, there are several brands that's Navident compatible ones. The one that we can use in America include the Selene bone fixation screw, and you have to be particular. There are some like particular size that will be Navident compatible ones. They are 1.5 by 4 by 6 and by 8 millimeter ones. So if you go longer than this one, or you go wider than the expected diameters, then they won't be recognized by Navident. The second brand that's Navident compatible one is the TrueFix bone fixation screw, and the size that's compatible ones are the 1.5 by 6 by 7.5 and by 9 millimeter ones. And this is the one we used in Taiwan. And the third one, that's the Abutment one. That's the compatible one, and the one that has been widely used in Europe. And the size that's compatibles are 1.2 or 1.4 in diameter, and 6, 8, 11, or 13 in length. So what can you see from the Navident when you use these compatible screws? It shows on the screen with the type of the brand of the screw that you use, and also the diameter and the length that you choose from the screen once you choose them as a registration point. So this is what you're gonna see on the screen when you choose the compatible screws. But sometimes the computer doesn't recognize them as expected. So like in this case, it's the TrueFix 1.5 by 8 millimeter screws, but you can appreciate it from the screen. The bone screw number 1 and number 3 are not recognized by the computer, while the bone screw number 2 and bone screw number 4 are recognized. When this happens, you can like try several attempts to remove it and click on the different part of the screw and see if it can become recognizable. If it's still not, then you will use them as just a bone screw as a secure point for doing the tracing. So like in this case, you will do tracing on bone screw number 1, bone screw number 3, and do the point registration on your bone screw number 2 and bone screw number 4. So this is what, if it happened, then this is the way you solve the problem. And also sometimes the machine could recognize the other bone screws as the one that they can recognize, and accidentally recognize it as, like in this case, they recognize the ortho screw as a Navibite. And we in this type of scenario, you have to choose the different point on the mini screw or the mini implant, and make sure until the so like when you click here, it shows Navibite, and then you have to try several attempts until it doesn't show as a Navibite, because for the Navibite, it's a fiducial that the computer can recognize. Once you touched it, they will recognize it as a Navibite type of fiducial, so which could create the registration failure or the registration inaccuracy. So when this type of scenario happen, you have to make sure you click on the different part of the mini screw or the mini implant that you use until it disappears. So these are the two different type of scenario. The first one is when you use the compatible one, and if it doesn't work, then it's easier to solve the problem because you just do the tracing. And if it's misrecognized as the compatible one, you have to choose the different side of the implant and make sure it doesn't show as the compatible ones. So these are the way how you use the bone screws. And let's move forward to see several different in different kind of clinical scenarios and how we solve the problem. And we will go through from the fully edentulous patient to the patient with teeth with extensive decay. And sometimes we also see the patient with failing dental implants, but they also need full mouth reconstruction. So this is the third kind of clinical scenario. So starting from the edentulous one, I'll have to say to place the bone screw, that's for a surgeon, that's a little bit difficult because you have to anticipate where the future implants are, and you have to imagine how the teeth are going to be set up, and try to make sure your bone screws are not in the way of your future implant. So like in this case, when you place the mini screws, you won't be able to know where your future teeth are until this procedure. When we do the superimposition of your teeth setup to your cone beam CT, this is how we do the superimposition from the denture that Dr. Kuo made. She will put on several fiducials, and the patient will wear this denture to take a cone beam CT together with the bone screws in the jaw. So after we do the superimposition, not until this step will I know where the future teeth are going to be. And then this is where I can start to plan my implants. So when I place the implants, you have to consider where your teeth are and where do you have sufficient bone to place the implant. So like in this case, the second bone screw are actually in the way of tooth implant that we plan to place at tooth number 26 or tooth number 42. So when this happens, this could happen because when you place bone screws, you just guess where the future implants are. And when this happens, you will be very thankful if you have placed more than 4 mini screws, because this one will be removed at some point of the surgical procedure. And also for the case that the previous case is the one we did before the Navident machine can recognize all these bone screws. So back at the time, we have to do the tracing. And for nowadays, the Navident can recognize all these bone screws. So when you click on the bone screws, you can do the registration in a very easy way. This the video will shows. So when you click on all the screws, they were recognized as Selene bone screw, just as the one you can appreciate on the screen. And when you are doing the registration part, we call it point pair registration. It's a lot easier than before. You just need to hold the tracer on the screw at the point where you click for registration, and the whole registration procedure will take about like less than a minute to finish it. Let's go back and see it one more time because it just happened too quick. When you click on it, back at the time you do tracing, it goes from 1, 2, 3 up to 100 and finish the tracing. And with the bone screw one, you just need to put your tracer on top of the mini screw, then it can be recognized and registered immediately. So after the registration procedure, you always do the accuracy check. This is the beauty of using the compatible bone screws and how easy it is. So the registration procedure will become very, very easy to execute. And in the previous version, or when point pair doesn't work, this is the way how we do it. So you just use it. You just use your bone screw as a tooth, a stable tooth. And you will have to trace on the bone screw going from 1, 2, 3 up to 100 until it's done. and one after one. So after you're done with all the tracing, so you can see the difference. This one, it takes much longer compared to the before this version launched, or when point pair doesn't work. So these are the ways to register your intraoral condition to your cone beam CT, and then you do the accuracy check. So either way works. Just the one, it's more time saving. The other one, it's more time consuming. And then the other type of bone screw, the reason why we use the other type of bone screw, this one, it's an this one is an ortho screw. The reason why I use ortho screw sometimes is because the bone screw, the compatible bone screws, sometimes they got loose because they are, the diameter, it's a lot smaller compared to the ortho bone screw. And also in length, the compatible ones are much shorter. So for some patient, the bone screw came off quite easily. But for the ortho bone screw, they are designed for stay in the mouth for a period of time. So I actually encounter less problem while using ortho bone screws as the bone screws. And also when the point pair doesn't work, it's a lot more difficult to trace on the compatible bone screws because you only have a small screw head exposed in the intraorally. So you have to just go around that bone screw head and do the tracing. But for the bone screw, there are many parts that can be used to for the tracing part. The one there's like a hex type of like here. So I feel like it stays a little bit longer, and also by doing the tracing, it's easier to recognize. So for some patient with very, very poor bone quality condition, in this type of patient, I go with the ortho bone screw. So this is the way we use it for registration, and just as the one you used when the bone screw cannot be recognized as the compatible ones, you use them as the stable landmark intraorally, and then do the tracing procedure. This is just another way to work on the case. All right, and then we're moving forward to the second kind of scenario when patients have teeth with extensive decay. In this type of case, if there are like extensive decay on the teeth, and it doesn't mean that you have to do the bone screw all the time. In this type of case, if the teeth can still hold a provision in a fairly stable position, then in this type of case, we can register with the fiducials on the temporaries, using them as a tracing material. So in this type of case, sorry, I'm running out of time. In this type of case, after you superimpose your temporary crowns to your teeth, you can use your fiducials or your landmarks on your scanning files as a registration method. So once you pick up all these points where you're going to do the registration, you'll do the same type of tracing method, and then just sliding on your teeth surface, and they will be able to recognize as the temporary crowns, so they can do the synchronize between your temporary crowns and the one you can appreciate on the cone beam CT. So you also do the accuracy check after you do the tracing on the surface scan. So this is another way to do the registration to use by utilizing your STL files. And then in the third case, this is the last one. The last one is in the very severe type of case. If you happen to have like one or two failing but stable implant with some certain type of bone landmarks, because in this case, you can appreciate the inferior alveolar nerve, it's in the very high position. So it's almost impossible to place a few more bone screws because it's very, you could touch the nerve accidentally. So in this case, I use these two implants, and also there's a bone peak at the patient's third quadrant. I use these 3 points as the tracing landmarks. And when you're doing the correct tracing on all these landmarks, so for this patient, after the tracing on these two implants and on this bone peak, what I care the most about is the patient's nerve. So by touching the mental foramen after I flapped it, you can appreciate that we also have a very accurate tracing. So from here, because you can be very sure you're away from the nerve while you're doing the implant placement if this is if you have a correct tracing. So how to trace? When you're doing the tracing, this is a very difficult tracing. This is the case where it's very hard to do an accurate tracing. So when you're doing the tracing, you have to go like all over around in the front and in the back of the implants. So you don't do it on only one side. It's better to go back and forth, and when you're doing the sliding motion, you have to make sure you stay close enough to the implants. And then especially in the bone part, you have to make sure you go broader, you go wide, and in the meanwhile, you stay close enough on the bone surface. And so this is how you do the tracing. You have to slide down the teeth, make sure you stay very close to the tooth surface and go back and forth. And now we have a new feature which will shows the trace registration on the screen. If you click on this one, show trace registration, it will tell you how accurate your traces are. So there will be several different kind of spheres showing on your screen. The yellow one, which is larger, the large yellow sphere, that's the point where you click on your cone beam CT for the registration. So you start from this point, and then you will see there are like green ones, the red ones, and the large blue balls ones. The large blue balls ones are the one where you start tracing. So you have to make sure the point you start tracing that stays close enough to the yellow ones. Though it's better that you can superimpose your blue ones to your yellow ones. At least they have to stay close enough. And then the green ones and the red ones means if you stay close enough to the tooth surface, it shows the green one. And for the red ones, it means you don't stay close enough to your tooth surface. If you're like a millimeter or more away from your tooth surface, it shows the red one. So this one helps you to do the registration. If you are not familiar with the machine or you're just a beginner in using Navident, you can turn on this one and see how accurate your tracings are. If you're doing this one correctly, when you do the accuracy check, you will get a very good result, a favorable outcome. All right, so I'll hand over to Selene to finish the last piece of our presentation.
Log out first. Okay, so we're running out of time. So for the final part that we are going to talk about, the latest feature would be the abutment plan. And this is actually very crucial for prosthodontists like me because you need to have the implant inserted in, but you eventually need to restore a crown. So if it's called a nice day, what a wonderful day, that would be the bone is perfect and the implant can insert in properly, just like this animation, and then you restore a crown accordingly, and the crown can fulfill all the parameters we just talked about, a premium quality of the prosthesis. However, things will never go as what you expected, especially in the failing dentition or fully edentulism. The bone geometry frequently resort atrophy severely up to the point that your implant, no matter how much you can graft it, you still need to place an implant within the bony confine. And that being said, is basically your implant has no choice but need to tilt it to a certain angle to fulfill this bony confine requirement. So if we need to restore a crown properly, then we definitely need something that correct this disparity in between the implant angulation along with the crown, so that we can still achieve all these premium quality parameters. And that is especially crucial for full mouth rehab implant prosthesis, because we want to provide the prosthetic part that's all be splinted together, so we can minimize the implant numbers while maximizing all the strength of the definitive prosthesis. That being said, if we need to have everything splinted together, achieving the passive fit, passive insertion, meaning that we have to have the implant angulation to be corrected into the certain angle that needs to be parallel. So both the disparity, as I just described, we need this particular parts, implant parts, to correct this disparity, and that is what so-called transmucosal abutment, also known, aka the multi-unit abutment. So the previous version that we basically planned on how to select the proper multi-unit abutment, transmucosal abutment, is we basically have the teeth that's been designed, which is where you can see the pinkish outer border of the tooth. And we plan the implant according to the outer border of the tooth through the center. So you can see in the middle of the screen, we have the implant planned in first at the center of the tooth, both mesially, distally, and buccolingually. Then we calculated the angle and the distance starting from the platform of the fixture till the till wherever you want the implant screw axis to be come out. That being said, for anterior teeth, you definitely don't want the screw axis to come out through the buccal side or incisal edge. You want to come out through the cingulum. So you need this multi-unit abutment, transmucosal abutment, to correct according to what you measure the degree, which is 17 degree. And that gives the I will give full credit for this new invention of the software, which is having you being visualized how the abutments are going to be adding on. And that helps you to have an idea whether all these implants are parallel and whether the angulation and the height is being brought up and corrected correctly. So nowadays, the way that we planned it is also we measure the distance and the angulation that we want to correct it. But we will utilize the new feature, the latest feature of the abutments that being added on. And you can see what this, the column, the section, the category that it's been popped up. You have different features of the abutment that you can be able to enter it in. You manipulated it so that could be fulfill what the implant manufacturer that you are using, the implant brand that you're using to, you just need to enter in all the parameters so that can corresponding to what the implant brand that you're using. So you can see the top part, you have the generic, so you measured it, and then if the implant brand that you use is one of the built-in implants that we actually have over here, that it includes Straumann, that includes Nobel Bell here, that includes Ankylos. So if you're having those implant brand, you can just select it from the generic part and substitute that into the implant brand that you're using. But if you don't, then just like me, you can select the angulation that you are going to change in the future by correcting the first column that I circled it out. I want it to be 17 to 20 degree. And the degree of the correction that literally has to follow what the implant brand that you're using, what the manufacturer of the implant, that they have fabricated out this standard type of multi-unit. So for instance, the implant that I'm using right now, that's Straumann. So Straumann basically has the multi-unit abutment that angulation can correct it to 20 degree to 30 degree. That's only 2 types. If it's for Nobel, then they have 70 degree or 30 degree. So it's either all these 2 or 3 numbers that you can choose from, and that's totally basically solitary by the company of the implant that you're using, the brand. So you have to select angulation first, and then the height of the implant abutment that corresponding to what implant abutment parts that you're using, along with the collar height, the soft tissue height that you have to measure properly to lift the implant abutment fixture junction away from the crystal bone, so that avoiding future potential crystal bone loss. And the final check is always the axis. As we said, you want to have like a full mouth rehab prosthesis, the splinted implant supported fixed dental prosthesis that's being able to passive fitting on all these implants, and then having this passive insertion that's clear. So you definitely need to double check upon each of the implant angulation as well as the whole picture to make sure that they're all somewhat parallel or within the confine that the multi-unit of abutment that you're using can be able to correct it. So the very, very last take-home message would be the strategy of navigation machine. Basically, it consists with the plan, which is the 30 minutes that I've been spending on to telling you guys that you have to define where future teeth are going to be by digitally design the teeth position. Then you superimpose your teeth position along with bone. So you plan the implant accordingly, whether you need grafting or you need to place the implant altogether. That consists the plan part. And that basically is what we typically explain to the all the audience. You know, you basically need to tell the machine where you are going to go in the future. The second part would be what Dr. Chiu just mentioned about. You have to tell the machine where you are. So you basically need to register your position along with what you have planned. So both of the position can synchronize together, and that allows you to do the third part, which is the place part. So that being said, thank you very much for your attending today. And these are all the warriors that from our country that they have been winning the medals through the Olympic Games. So I hope you enjoy the games as well as our presentation today. Thank you very much. And we're now open to question and answer. Beth, you want to introduce the following course?
Sure. Our next program that we have coming up is actually a live program that's going to take place in Toronto on Saturday, September 25th. And this will be focused on Navident and endodontic applications. It's a full day hands-on workshop. If you have any questions, you can contact me or register online with Kamisha. And for those of you that have attended this course, if you decide to go to the one in Toronto, we are waiving the tuition. Just mention the fact that you attended this webinar and the $99 will be waived. So thank you so much. Doctors, that was a fabulous presentation. I really appreciated it, learned a lot, and I think our attendees did as well, I'm sure. For those of you that are looking for your CE documents, you can find them on this link. And again, we do have some time for Q&As. If anybody has any questions, please type them in the chat box. Otherwise, we wish you all a great day or a great evening. Any questions? You must have been both very thorough.
Maybe they're just being shy. So
That could be.
Yeah, you guys can email. That's a lot of, as I said, 30 minutes or an hour for full mouth rehab, especially digitalizing full mouth rehab. It's actually heavy. And especially we're
Mhm.
focusing on a lot of new features that's assisting
Exactly.
us, on planning. So we are open to any questions in terms of email. So if you guys are, you guys want to discuss anything further, you're too shy to discuss about it at the, at the platform, you're always welcome to email us. So
And you all will be getting a recorded version of this presentation.
Mhm.
So again,
mhm.
watch it. If you
Yeah.
have any questions, the doctors have graciously offered to take them via email. So we
Mhm.
thank you very much.
Mhm.
Thank you,
Thank you.
doctors.
Thank you.
Thank you.
Great program.
Thank you, Beth.
Have a
Thank you.
good
Have a good evening.
You too.
Yeah.
Take care. Be
Bye.
well.
Bye.